Hi, I'm Brett Stetka, Editorial Director at Medscape, and welcome to the F1000 Practice Changing Minute, where we report on highly rated studies that may change clinical practice. Our commentary today covers the study Efficacy and Safety of Regional Citrate Anticoagulation in Critically Ill Patients Undergoing Continuous Renal Replacement Therapy from Dr. Zhang and Hong Ying and published in Intensive Care Medicine. The faculty of 1000 has given this a ranking of must-read with a factor of 8, and the following F1000 commentary on the study was written by Dr. Helen Oudemans van Straten from the Ons Lieve Vrouw Gasthuis in Amsterdam. In her commentary, Dr. Oudemans van Straten wrote, "Due to the need for extracorporeal anticoagulation, continuous renal replacement therapy, or CRRT, opens a struggle between clotting and bleeding. There must be this must-read meta-analysis compares regional anticoagulation with citrate to heparin anticoagulation for CRRT. It shows that citrate is superior to heparin for the endpoints of circuit life and bleeding. 4 comments should be made here. First, metabolic monitoring is a prerequisite and the local protocol should be strictly followed. Second, results are heterogeneous, likely due to the different citrate modalities in use. Third, the present results do not apply to patients with an increased risk of bleeding because these were excluded from the randomized studies, whereas at the same time, the main incentive for using regional anticoagulation with citrate is that citrate doesn't increase the patient's risk of bleeding. Thus, though not shown in randomized studies, citrate also, and even primarily, is the preferred option for circuit anticoagulation in patients with an increased bleeding risk. And lastly, or fourth, the randomized controlled trials excluded patients with liver failure because liver failure is associated with delayed citrate clearance. Liver mitochondria are an important site of citrate metabolism, though not the only one, and because patients with liver failure often have an increased risk of bleeding, several studies explored the feasibility of the use of citrate in liver failure. They show that citrate is feasible in this population if intensified monitoring of citrate accumulation is applied and dose is reduced if necessary. Notably, the dialysis modality may be preferred in patients with liver failure over the pure filtration mode because dialysis can be done at lower blood flows and therefore a lower citrate dose can be used. And altogether, more and more evidence is emerging that citrate is the preferred anticoagulant modality in critically ill patients with and without increased risk of bleeding if metabolic monitoring is adequate and the protocol is followed. The use of citrate is feasible and rewarded by less bleeding, while circuit life tends to be longer. Citrate may even be considered in patients with liver failure if monitoring is intensified and dose is reduced if necessary. Whether citrate improves patient survival needs to be studied further. And with that, this concludes today's commentary from Dr. Helen Oudemans van Straten. For the F1000 Practice Changing Minute and Medscape, I'm Brett Stetka, and thank you for listening.